All right, welcome to today's Explainer. Today we're diving into a story with incredibly high human stakes, some absolutely mind-blowing scientific breakthroughs, and a relentless fight against a devastating genetic disorder. And it all starts with a little toddler, affectionately known as John John. He's right at the center of this incredible medical frontier. I mean, we're talking about a kid embarking on a literal journey across the globe to try and halt a severe progressive disease before it can steal his mobility and ultimately his life.
Imagine making an urgent, desperate trek all the way from Taiwan to California. That's exactly what John John and his family did. Their destination was a groundbreaking clinical trial over at UC Davis Health. And they weren't traveling just for standard care, or just to manage his symptoms. They made that massive trip for a chance to actually rewrite John John's genetic destiny. You see, John John was diagnosed with Duchenne Muscular Dystrophy, or DMD. It's one of the most severe types of muscular dystrophy out there, a condition that progressively weakens literally every single muscle in the body, right down to the heart and the lungs.
Okay, let's dive into this, because truly understanding what John John is up against really means we need to look at the biology. Now, Duchenne Muscular Dystrophy isn't an incredibly common disease, but it is the most common form of severe inherited muscle disorder. It affects roughly 1 in every 3,600 male births. To put that into perspective, that means thousands of families all around the world are waking up to the exact same daunting reality as John John's family. Now, you might be wondering why this predominantly affects young boys. Well, we have to look at how it's inherited. DMD is what's called an X-linked recessive genetic disorder. The mutated gene responsible for all of this lives on the X chromosome. Because boys have one X and one Y chromosome, if they inherit that mutated X, they literally don't have a backup. They're going to develop the disease, for sure. Girls, on the other hand, have 2 X chromosomes. So if one has the mutation, the other healthy X chromosome steps up. It acts as this amazing biological backup, producing enough of what the body needs. This means females are typically carriers. They can pass the gene on, but usually don't show the severe symptoms themselves.
So what is this mutated gene actually failing to do? Well, it's failing to produce a protein called dystrophin. Dystrophin is kind of our biological villain in this story. Actually, scratch that. The absence of it is the villain. Think of dystrophin as a heavy-duty biological shock absorber, or even like a vital glue that keeps your muscle cells structurally intact. Every single time you move, jump, or even just take a breath, your muscles contract. Without dystrophin, that simple, everyday active contraction actually damages the muscle cells. They become super fragile, they tear easily, and over time, the body just can't repair them fast enough to keep up.
And this brilliantly illustrates just how delicate our genetic code really is. Duchenne muscular dystrophy happens when a mutation completely halts the production of functional dystrophin, which leads to a really rapid, severe decline. But there's a closely related condition called Becker muscular dystrophy. In Becker, a slightly different mutation allows the body to produce a semi-functional, shortened version of that dystrophin protein. Because they have at least some working shock absorbers, patients with Becker experience a much slower, milder form of the disease. They often live well into their 50s and 60s. So that difference between having absolutely zero protein and having just a little bit, it's absolutely massive.
Moving on to Section 1, the clinical progression from micro to macro.
So how does the microscopic absence of just one single protein snowball into a whole-body progression as a child grows up? Well, the diagnostic journey usually kicks off when a toddler seems a bit clumsy, or maybe they're delayed in learning to walk or stand. When a doctor suspects DMD, they follow a pretty specific path. First up is the physical exam, looking for unique signs of weakness. Then comes a blood test to measure something called creatine kinase, or CK. Because those muscle cells are constantly tearing and breaking apart without their dystrophin glue, this CK enzyme just leaks directly into the bloodstream. In a child with Duchenne, these CK levels aren't just slightly elevated. They can be 10 to 200 times above normal by age 2. Finally, doctors use advanced genetic DNA testing to confirm the exact mutation, which, as we're going to see in a minute, is absolutely crucial for modern treatments.
During that initial physical exam, doctors are looking for a very specific, tragic, yet mechanically fascinating hallmark. It's called Gower's sign. Because DMD weakens the proximal muscles first, meaning the muscles closest to the core of the body, like your glutes and your quads, a child simply doesn't have the leg strength to stand straight up from sitting on the floor. Instead, they have to roll over, push their butt into the air, and literally use their hands and arms to walk up their own legs just to push their torso upright. It beautifully but tragically demonstrates just how profound that lower body weakness really is.
Unfortunately, this weakness follows a pretty relentless chronological upward march. Between ages 2 and 4, you're looking at delayed walking and frequent falling. But as that microscopic muscle damage accumulates, the weakness spreads higher up the body.
By age 10 to 12, most boys lose the ability to walk independently and have to start using a wheelchair. Then, as they enter their teens and 20s, the disease reaches the really critical upper body muscles, specifically the respiratory muscles you need to breathe and the cardiac muscle of the heart itself.
Now on the inside, the physical toll is just devastating. Because the body can't regenerate muscle fast enough, the dead muscle cells undergo what's called fibrofatty replacement. Essentially, they get entirely replaced by fat and scar tissue. And this leads to a really cruel physical irony: calf pseudohypertrophy. Pseudo meaning false, right? So a young boy with Duchenne might have calves that look massively enlarged and super muscular, but they're actually just filled with useless fat and connective tissue. Meanwhile, the weakness in the back muscles leads to rapid severe scoliosis that very often requires spinal fusion surgery. And weakness in the heart leads to dilated cardiomyopathy, a fatal weakening of the heart's ability to pump blood.
Okay, let's head into Section 2, Current Management and the Future of Treatment, How Medicine is Fighting Back.
Let's move to and see how this builds into an incredible story of resilience and medical innovation. For decades, you guys, this was a universally grim diagnosis. The entire foundation of fighting DMD and pushing back against that decline relies on intense, multidisciplinary supportive care. Daily use of corticosteroids like prednisone or deflazacort is absolutely huge. They suppress inflammation and actually slow down the muscle damage. That alone can keep a child walking independently for several extra years and dramatically drop the risk of severe scoliosis. Combine that with rigorous physical therapy to keep joints from freezing up, the early use of ACE inhibitors to protect the heart, and nighttime breathing assistance, and you can completely alter the trajectory of this disease.
And because of these incredible advancements in respiratory and cardiac care, we are seeing some wonderfully hopeful shifts. Historically, boys with Duchenne rarely survived beyond their late teens. Today, thanks to standardized, comprehensive care, survival into the 30s, 40s, and even beyond is becoming far more common. Young men with Duchenne are going off to college, they're building careers, and living full, active lives. But here's the best part: researchers aren't stopping at just managing the decline anymore.
Modern therapies are literally starting to hack the genetic code itself. We now have a class of drugs called exon-skipping therapies. Remember earlier when we talked about Becker muscular dystrophy, where a slightly different mutation creates a shortened but functional protein? Well, exon skipping theoretically works like a genetic patch. It skips right over the faulty part of a Duchenne patient's gene to coax their own body into making that Becker-style, semi-functional dystrophin. Plus, we also have newly approved drugs like HDAC inhibitors that actively turn on genes to help muscles regenerate and stop that dangerous scar tissue from forming in the first place.
Which brings us right back to our toddler John arriving at UC Davis for that groundbreaking clinical trial. This trial was for a brand new drug called Elevates. There's this great quote from the researchers that really hits the nail on the head. They said, "The drug Elevates is seen as a breakthrough because it seeks to treat the root cause of DMD and not just the symptoms. That is a monumental shift in how we approach this disease."
So the crucial point is this. Elevates is a full-blown gene replacement therapy. Scientists literally took the massive dystrophin gene, edited it all the way down to its most vital, essential components to create what they call a microdystrophin gene, and packed it inside a harmless, hollowed-out virus. Through a single, one-time IV infusion, those little viral couriers travel all throughout John's body, enter his muscle cells, and deliver a completely new functional set of genetic instructions. His muscles are suddenly taught how to produce their own biological shock absorbers, potentially halting the progression of the disease right in its tracks. No way around it. That is just incredible. It truly is a total marvel of modern science. We are watching a historically fatal childhood disease inch closer and closer to becoming a manageable condition and eventually maybe completely curable. John's massive journey across the world really represents the hope of thousands of families, and it leaves us with a pretty profound question to ponder. If a single infusion can rewrite the destiny of a toddler's muscles and literally give them back their future, what incredible limits is gene therapy going to push next? Thanks for joining me on this explainer. Keep questioning, keep learning, and I'll see you all next time.